I'm outside today for perhaps the first time in a number of weeks. Some of the rules in the UK have been relaxed, and it's been a very difficult period, I think, for everybody. And indeed, it's been tragic for large numbers of patients, and that includes cancer patients, which we know are at increased risk. There have been two phases of this pandemic so far. An initial phase when there was concern that healthcare systems wouldn't cope, and a lot of cancer treatment was cancelled based off that. That concern has now passed, and I think that in most countries, almost all countries, that initial fear luckily has passed, and we're now back to treating cancer patients. But that's not treating cancer patients the same way as we were treating them. There have been some really important changes. We're having to make sure our hospitals are more aseptic. We're letting less people into the cancer centres, so we've stopped visitors into the cancer centres. We've put checks on the doors to make sure that patients are well, and we're also randomly testing doctors and patients to make sure our infection rates are low. The balance of risk and benefit has changed for some treatments, and particularly we know that the risk appears high in cancer patients, in elderly patients, and in diabetics, for example. And so when we're thinking about new treatments, we need to reassess the risk-benefit ratio. And it may be, for example, adjuvant chemotherapy in bladder cancer, where the benefits are modest. It may be that that risk-benefit ratio has changed, and in my opinion, that is the case. But things like frontline immune therapy for kidney cancer, which initially was felt to be a concern because it was uncertain about whether we could treat the patients if they became unwell, that's changed now, and I think we should be treating those patients as we were before. And from my perspective, not that much has changed in the kidney pathway, although patients need to realise that visits to hospitals will continue to some extent. Many of them have gone video conference instead of face-to-face visits. But clearly, if you're on systemic therapy, you are going to need to come to hospital from time to time. And of course, there's additional risk associated with the infection that needs to be considered. So with good risk disease in kidney cancer, there may be an increased group of patients who are looking for surveillance rather than intervention with sunitinib or oxypembro. But those patients with more aggressive disease, I think they should still be treated with either oxypembro or ipi/nivo, and my current feeling is both combinations are safe. We continue to sequence VEGF-targeted therapies in the second and third line therapy. So it's not back to business as usual. Things have changed. We're more aware. The risk-benefit ratio has changed a little bit, but essentially we're not really changing our treatment paradigm as things currently stand. If, heaven forbid, there was a second peak of this process, that may change again. But as it currently stands, I think this is a good opportunity to be treating our patients because the risk in our hospitals, the positivity rate is significantly less than 1%. And I think that gives patients the reassurance that we can treat them safely.